Hi. Hello. So today we're going to work on nursing management for our obese population, and it also includes bariatric nursing, which used to be a much bigger deal prior to all the weight loss drugs that have come out in the last 5 years. And so I have some FYI, so not on the exam, but FYI content at the end of this about GLPs because it's highly likely that you're going to be treating people who have had um, use of GLPs, most likely the shots. So we're going to go over all of that, and it's not going to be on the exam, but I want you guys to know it because your patients will probably be benefiting from these meds. And I'm also going to talk about bariatric surgeries, but I've pared it down significantly because you might end up seeing in a patient's history that they've had a bariatric surgery, and this will be on the exam. So you need to know more about, like, what does a bariatric surgery usually entail? What should I expect from my patient? And then just dealing with patients post-op anyway is very helpful to know. And so this will be our larger population that tends to hold on to anesthesia a lot longer. It does hide in fat, and so you're going to have to watch them for a longer period of time for any kind of respiratory depression and just trying to get on top of their pain post-op. So we're going to go through all of that. So nursing management of our obese population. And I've just updated this information. So I got this from the WHO, which is a worldwide health organization. And some of the things that are really important to notice is that 18 years and older in 2022, 2.5 billion adults were considered overweight. And we're going to talk about measurements and what that means. And of those, 890 million were living with obesity. So overweight, obesity, morbidly obese, it's kind of a progression. It's just as much as, like, normal weight, underweight, and then anorexic or severely underweight, which also has a progression going in the other direction. And then the biggest issue with this is that it's generally kids now that are overweight. We're seeing it from a younger perspective, and that's alarming because a lot of different comorbidities come along with that much weight. The body has to work that much harder. The joints have much more pressure on them. So we're just keeping an eye out and trying to figure out how to manage our patients. So you have primary obesity, which is the excess of caloric intake versus what the body's actually using up, or the metabolic demand. And then you have secondary obesity because a lot of people can get it from different meds that they take. Like people on long-term steroids tend to have a lot of body weight, corticosteroids specifically. And then, of course, there's congenital anomalies where you just don't process your hormones the right way. And so maybe your hunger never gets turned off. And then there's just also a lot of other things chromosomally. So I'm also wondering if chromosomal issues are going to move to primary at some point, because we are uncovering a lot of genetics behind obesity. And we kind of previously assumed that it was just habits, so, an obese child has obese parents. We're like, oh, okay, they all eat similar things. But now we're starting to realize that actually that probably goes deeper into genes and whatnot. And that's going to be something that we'll be thinking about more probably in the next 10 years. So the way that we measure body mass, we don't do it very much because BMI, or body mass index, doesn't take into account different things like muscle mass, the variations in muscle mass, and even bone density in different people. So again, genetics at play, or age, sex, ethnicity, doesn't actually attend to any of those. So this is slow number one. I wanted to make sure you still knew body mass index because it's probably going to be talked about. And overweight is generally considered 25 to 29.9. Obese would be more than 30. And then you can see obese class 3, I believe. We tend to call them morbidly obese in the hospital. You might get that on a report. And so they would be over 40. And that was the group that was highly recommended the surgeries. So that's why we want to talk about those numbers so you kind of understand where medicine has been going with this. And so this is kind of how you diagnose it. This is your diagnostics, right? So your kilograms weight divided by your height in meters. And so this is all in metric. And you can find tools that automatically change it over to our, I think called imperial measurements, so that you understand like how it's done. I just want you to make sure you know that. All right, so a BMI of 30 indicates a greater risk for health problems, more visceral fat, means more cardiovascular and metabolic syndrome. We'll talk about metabolic syndrome in a moment. The leading health organizations actually recognize obesity as a chronic progressive disease, so it actually is now considered a comorbidity, not a cause of everything, but like it's actually also part of it. And so we're tackling it from a different perspective now. I don't have a lot on that, and I have to learn more on that so I can present it to you guys eventually. Second leading cause of preventable death. I think the first one is guns. Third leading reason for liver transplant, or NAFLD. Do you guys know what that is? Non-alcoholic fatty liver disease. You'll see that in your comorbidities for your patients on report. And then, of course, now we're realizing there's a strong genetic and biological basis. And then, of course, people are put into two different categories. You have the gynoid obesity, which is going to be more lower limb, hip, lower abdomen, legs. And then you have the android obesity, which can be more chest, shoulder, gut. So there are different things that we can expect from our obese patients that have these various shapes. For the gynoid, a lot more varicose veins, a lot more issues with bones. Trapped fat is stored as triglycerides. And remember, a lot of estrogen is found in fats because our body just holds on to it. And then on the android side, the more apple-shaped folks, more heart disease because they're carrying more of the weight up near the heart, metabolic syndrome, and even cancers. So again, it's multifaceted. It's not just one thing. Your patients are not lazy. They are not just eating crap food. There's way more at play. So you have to leave judgment out of this when you're thinking about it and when you're dealing with patients that are going through this. Because you can imagine if you've been large since you were little, how much shame that you've had to endure and all the psychological burden of being shamed for things that really weren't necessarily in your control anyway. So you have to learn that empathy, putting yourself in their shoes. What is this like? You want to help them out bedside because you want them to feel some dignity in their care. So you want to make sure that they are also letting you know, yeah, that's a good way for me to turn. I can turn that way, or I can grab that. Yeah. So you work with your patients. But remember, it's multifaceted. So we're beginning to think genetics is really important in this. The environmental causes behind it, like things like pollutants and other things like, you know how they call neighborhoods that don't have like a proper good level grocery store, they'll call them food deserts because it's just like gas stations and fast food. That's environmental. In addition to things like pollutants, you know, other things that could be going on in an area of the world. Biochemical, so biochemical in your brain, and then behavior, like what are your habits? So coming to the genetic portion, I actually did an experiment on this in Boston University when I was an undergrad there. And my friend and I were undergrads, but we took a graduate level course in neuroscience. And we got to study the mice that they were finding had these genes that made them a larger mouse. And we made little t-shirts for our presentations, and the grad students were not impressed with us. But they do find that there is a gene called FTO that is a strong link to larger BMIs. So we know there's something going on there, right? It also could be genetically not turning on or not turning off various hormones like leptin or ghrelin, which are things that tell your body that you're full. Insulin, how your body manages insulin, how it moves all the sugars into the cells. These are things that your body might have at the brain level, a malfunction of sorts. So we want to just remember these things so that we know how to treat our patients with dignity, and maybe even update them if they ask, update them on some of the research that's come out about causes. So some of the health risks of obesity, the big ones I want to point out, yes, psychologic. There's a lot of, shaming, having to pay more to go someplace because you take up too much room, things like this. It's just the amount of shame that is thrown into our obese patients' worlds. Of course, there's psychological draining, but there's another thing that I've noticed and have found research around was especially women, some men that were sexually abused as children tend to become very large. And I imagine there's a psychological way where they are not even conscious about it, but if they maybe gain more weight, they're not seen as sexual objects. And for someone who comes from trauma, that could be a solution. Unfortunately, it leads to a lot of other problems, and so they have to work through some of these things. Metabolic, we're going to go over that, but see the polycystic ovary disease, PCOS, you're going to probably meet more and more people that have been diagnosed with this. These tend to be women that are a bit bigger, and it usually has something to do with hormone imbalances that create more fat storage. And then they are also have abnormal periods, things like that. So polycystic or PCOS is usually at play there. The respiratory issues, which we'll continue talking about, especially post-surgical. The reproductive issues, the musculoskeletal issues, all the different pains and aches that folks like this have to endure, all the cardiovascular issues, the liver gallbladder. Remember that NAFLD. You also have NASH, which is non-alcoholic steatohepatitis. It's very similar to NAFLD. Gallstones that can cause blockages within the system. The genital urinary issues, especially nephrologic, like the ESRD, the end-stage renal disease, all those things, because once the kidneys start going, it usually takes the heart with it, and vice versa. Once the heart starts going, it takes the kidney with it. And then, of course, a lot of cancers can come from that. So remember, with metabolic syndrome, you're dealing with 3 out of 5 different things that are abnormal in their labs. So the first one would be that apple-shaped body, the android obesity, where they're holding more fat up in the upper portions of their body, the high triglyceride level being over 100, and then the low good cholesterol. So you want to remember cholesterol in that one. The good one is low, it's too low. High blood pressures, SBPs over 160s, and then high fasting blood sugars. And then you'd probably also pull an A1C on this patient. So you guys don't need to have this memorized, but you definitely want to know this for your NCLEX, because it's very important and you need to know this type of information. And that way you can also point it out to doctors if they haven't noticed something like that. I don't see metabolic syndrome, and maybe we need to consider that for this patient. Okay, so with collaborating, remember we can always write referrals. We can refer our patients to dietitians to get nutritional support. We can refer them to physical therapy, especially if they're having a lot of the bone and joint problems. We can talk to them about behavior modifications. Maybe it's time to start dealing with psychiatry or even psychologists. And then, of course, support groups to find other people that are dealing with the same things that they are. Referrals are very easy to write, and we generally don't need doctors to sign off on our referrals. So just always keep that in the back of your mind. Oh, we've also gone through SLOW 3 about the genetics, and the metabolic syndrome is SLOW 2. Okay, now we're on to SLOW 4. So with bariatric surgeries, you're going to be doing, you might see in their history one of 3 things. A restrictive surgery where they reduce how much food the person can process in terms of their stomach or intestines. You might see a malabsorptive surgery where they bypass certain things and so the body doesn't process the food as well, or you might see a restrictive malabsorptive surgery. And so that's usually what they're doing nowadays. This is an evolution of surgeries that they've been doing. In order to have been, because they're probably not using them as much anymore, they're probably going with the GLPs now. In order to have been considered for these surgeries, you had to have a BMI of over 40, so there's that morbid obesity. You had to be 18 years or older. You had to understand and be able to sign off on the risks and the benefits, because remember everything, like 6, 7, risk versus benefits. You've had to have been obese for 5 years and tried and failed different things. Also, an ideal candidate would not have any liver problems or serious endocrine problems, because if those are at play, then we can correct those. You don't need a surgery in order to correct those. They should usually be seeing a psychiatrist and making sure that once they've had the surgery, they have the social support in order to heal. The availability of the team and the healthcare providers needs to be within reason. These people need to have the ability to talk to their team, and surgery would lower or eradicate high-risk health conditions. So all these things are taken into consideration. And here's a bunch of the different types of surgeries. And so you might end up seeing patients that have had large scars from their surgeries, but most of them, like 90% of them, are now done laparoscopic. They got real good at these, where they go in, with just 2 or 3 points with the robots, and they go in and they can do all of this while the doc is literally like over behind the patient, like controlling it through some type of computer control. It's crazy to see the doc like across the room and the patient on the table. So these are the different types. You can see banded, where they're trying to create a smaller pocket or reserve for food. The gastric binding or banding does it the other direction. The sleeve, where they kind of slice and then bring the stomach together so it's smaller and can't expand as well. You have the malabsorptive one, like where they're creating diversions, and the Roux-en-Y. So I know that sounds weird, but you can see this last one, Roux-en-Y. I think it's French. It's a bypass procedure, and so that's one of the other ones that's both malabsorptive and restrictive. So before a patient would go in for these surgeries, we always make sure we understand their baseline respirations, because it's very important. This is slow number 5, by the way. And we want to make sure we understand, like, what is their normal rate? What is their normal oxygenation? Because we're going to need to respond. Like I said, anesthesia can be held in fats. And so a post-op patient might still be very out of it and not breathing very well after surgery. So we want to pre-op understand where they're coming from. We want to instruct the patient in the right way to cough after surgeries, where they're not compromising their stitches, using the pillow on the gut, deep diaphragmatic breathing to keep pneumonia out of the lungs, and then methods of turning and positioning to prevent all the pulmonary complications. Wound infection is going to be very important here. We want to be able to see and make sure that they are staying hissed. We don't want that dehiscence, where the wound kind of like doesn't articulate anymore. It kind of busts a staple or a stitch. So we're going to make sure that we're watching these wounds, instructing them on how to take care of their wounds, because ultimately we don't want them in the hospital for very long. So the more they know before, the better their post-care will be. And then, of course, frequently bathing, and just remember to keep them fresh so they feel better about their body while they're dealing with all of the surgical issues. And then the other thing for that, by the way, is to reduce infection in the wound by having them doing a lot of bathing prior to the surgery and the day or two before, usually with things like chlorhexidine and whatnot, to help kill off any of the bacteria that's there so that we can reduce infection of that wound. So after, this is going to be slow 5 and 6, we're going to make sure we have the right blood pressure cuff. We're going to make sure we have the right gown. We're going to make sure we have the right wheelchair, the right bedside commode, the right bed, especially the bed that has the over over the head trapeze bar so they can be part of their movement. We don't want them deconditioning post-op. So this is just the same for any patient, but we're just making sure that they stay conditioned before they go home. In severely obese patients, we're going to definitely watch that O2, probably keep them on a continuous O2, especially if they're on very strong pain meds. If they were on previous pain meds before, they might need more pain meds since their body's used to it. So you're going to want to make sure that you're watching that respiratory rate, making sure it's safe, maybe using alternate, methods of pain, like acetaminophen if their liver's good, maybe even some muscle relaxants so they don't get too spastic with pain. We're going to try and get them up so they don't decondition. And we're going to try and ambulate them frequently so that they're moving around. We're going to be using those sequential compression devices to keep clots at bay post-surgical, and then maybe heparin shots, Q12, and then hopefully discharge within a few days. Once they're home, we're making sure that they understand how to eat with their new body, with their new stomach. This is a very important slide. So post-procedural diet is really important. We're going to go for high protein, low carb, low fat, low roughage. And so that's hard to do, right? We don't want to just slap a steak in front of them or like a big thing of doughy bread. That's not a great idea. Low roughage, so not a lot of veggies and fruits in the beginning. We're going for a low residue diet. Remember BRAT? That's the low residue diet. That's kind of simple for the body to manage when it's been inflamed or sick with gastritis. So you're going to be doing a lot smaller meals frequently. They're going to encourage them to not drink as much water with food because the space that the food is going into is most likely much, much, much smaller than they're used to. And they're used to eating this much. Well, we have to remind them you can't do that anymore because the space the food's going into is smaller. So don't do waters and drinks with your food. You have to kind of space all that out. And then cobalamin, do you guys know what vitamin that is? B12. There's a lot of nerve damage that can happen if your B12 levels are low. Things like nutritional yeast added to food can help maintain that, but they may end up just needing injections or sprays to avoid the potential for anemia. Let me just make sure. Yeah, so we're going to make sure that they know that they have to eat less, but most likely more often. So also at home, a couple things we have to think about. So that anemia is something we have to think about and keep an eye on after they've had the surgery because they're not taking in as much food. And then most likely they're also changing up their stomach acid and how much stomach acid is produced, especially in terms of allowing the tissue in that area to heal. They may need, meds for that, which changes the stomach acid. And when you start changing their stomach acid and they become a little bit more alkalinic, certain vitamins are no longer absorbed as well. And so things like iron absorption is going to go down. So we're worried about anemia with that. We're worried about those vitamin deficiencies because of the same thing. We're worried about diarrhea because now food is moving faster through their system, especially if they have the malabsorptive surgery, but most likely they've had the dual restrictive and malabsorptive. So the food might not be getting broken down and absorbed, so it might be coming out faster. And then, of course, the psychiatric problems of everything just changing. We have to help them through all of this. And then also we're looking at, this is flow 6 again, possible complications like peptic ulcer formation, dumping syndrome, which we'll talk about in the upper GI lecture, small bowel obstructions. We're going to also talk about that in lower GI and upper GI, but it's essentially where it's not like poop getting stuck in the system. It's like literally the tissue of the GI system is inflamed and not allowing anything past it. And especially after you've been messing with it with a surgery, it's potentially going to become inflamed. Gallstones, because things are moving slower. GERD is very common. If things are not moving down, maybe you're eating too much, things are coming up. You're having a lot of heat come up your esophagus. So all these things have to be communicated to the patient. And the evaluation is expected outcomes. Like, we're hoping long-term that there's weight loss. We're hoping that weight loss is somewhat slow so that it's a little bit more meaningful for the patient. It is pretty well known, especially if you watched any of those shows like Biggest Loser and whatnot, that it seemed that very rapid weight loss was more difficult to keep off when you're not under the watchful eye of a whole team. And it has also been mentioned that the GLPs have also shown that when people come off the GLPs, they gain the weight back. And so long-term weight loss is more about incremental and slow weight loss. It seems to be a bit more suggestive of the right combination of behavior, medication, surgeries, whatever they are. And the longer it takes to lose the weight, more likely you're not going to gain it back as quickly. Improvement in obesity-related comorbidities, that's kind of the whole thing. Integration of healthy practices into their lifestyle. They probably still need help with that. They need the support, how much their life has changed. Their self-image might be improving, we hope. And they must monitor for all the adverse effects that can happen, like the ones on the previous slides. So we're just keeping an eye out and making them well aware of what's to come. Older folks are also much more obese nowadays than they have been in the past. So these are people, I believe, over 65 who are considered obese, and it's more common in women than in men. And they are not moving as much. Maybe they have a lot of pain. And so it just sort of, keeps happening to them where they're not able to lose weight. And then, of course, that also exacerbates other age-related problems like with your body, with your comorbidities. And that's slow number 7. And now we've come to our, FYI, even though it is in the slows, FYI, I'm not going to ask you questions about GLPs on the exam, but I want you guys to know what they are because it's important. As of right now, I do not believe these will be on the NCLEX, but that could change. So by the time you guys take it, maybe they'll add. We will let you know if they do. So the newest medical treatment, why cut someone open when you can just have them inject? This is a big deal. And the way that the GLPs work, or the mechanism of action, MOA, mechanism of action, is multifactorial. So it can stimulate insulin to be secreted, so it pushes all the sugars into the cells appropriately. It can inhibit glucagon release from the liver, so it's not making more sugars. It can slow gastric emptying, so you feel fuller for a longer period of time, and increases satiety, which then decreases your appetite. So if you feel fuller, then you're not going to be as prone to eat. The dosing on these, we do know about the sub-Qs that will be weekly. That's most of the ones that I think are being approved by insurance so far. I mean, who wants to stick themselves twice, right? A day? No. But a week, yeah, you can probably step up to the plate on that one. So we're learning that there's more orals coming in. The orals that I've seen are the Ribelsus or something like that. And then the Roe, I think, is the other one that I've seen ads for. And then there's a new PO formula that's coming out. I've seen some ads. I think Weight Watchers is trying to trademark it, and you have to go through them to get it. So there's definitely things coming up. But these are helping. I just know that my friends that have taken it have mentioned that they just don't think about food very often. And when I spent the next day after hearing that, I was like, wow, I think about food a lot. Like, I'm always thinking about what, and I also have a family, so I'm feeding my family. So I'm thinking about food in that regard, but just in terms of like, I wonder when I should eat lunch today. I wonder like, did I have enough for breakfast? I do think about food quite a bit, and apparently it takes that chatter away. And by the way, it also helps with a lot of addictive issues. A friend of mine was able to stop drinking, and he was like pretty much an alcoholic when he started on this med, because he said it just took that chatter away, that anxiety away. And he was able to focus more on going to the gym, having healthier social interactions, like all these different things changed for him when he went on this drug, because it just quieted down some parts of him that were pushing him into more unhealthy behaviors. That's what he said. So side effects, you have the common ones like the nausea. And most of these, by the way, will improve over time. So if you stick with this drug by, the third week or so, generally you can work through some of these side effects and then they're not necessarily problematic anymore. Vomiting, diarrhea, constipation, one or the other, like good luck with that. Abdominal pain with bloating, loss of appetite. I mean, that's kind of the intended effect, but we still want you eating because you still need to get all the nutrients, vitamins, elements, everything from your diet. But the one that would be a stickler is the fatigue or low energy, and it's probably just taking time for your body to get into the new season. I almost said season. I guess that works, but it could also be like seasoning, like on food. Forget about it. It's very punny. Indigestion and reflux. That's not great. Those are not going to be fun. So here's some of the less common ones: that rotten egg burp, dehydration from nausea, vomiting. You definitely have to keep an eye on these. You definitely want to talk to your patients about that, especially if they're going to go home on these meds. You might be the one having these conversations with them. Serious but rare is that pancreatitis, so the inflammation of the pancreas. The kidney injuries that can happen maybe from the nausea, vomiting as well. If you're just not, your blood pressures are going down, your kidneys are not being perfused, maybe you're not making as much urine. There's a lot of problems that could happen. So you do have to still stick to drinking, eating, all the GI issues, the malnutrition, the obstructions that are possible, allergic reactions. And then they always say in the commercials, don't take this if you have medullary thyroid cancer. So that's what they found. And then other things to think about: hypoglycemia. If you're sending out a lot of insulin, your body's putting all the sugar away, then that might mean that there's not enough left in the blood for whatever you need. So you might see symptoms of that. And especially if you're coupling it with another anti-diabetic medication like the sulfonylureas. Slowed gastric emptying could also mean that your medications don't get absorbed as well. So you may end up having to change dosing on medications. And then maybe over time, eradicating the medications. But when you still need them, think about how your body absorbs them and talk to your doctors about that. Mood or mental health changes. Remember SI, suicidal ideation. It's always very important to talk to your patients about, especially if you're picking up on that vibe from them. Just saying, are you thinking about hurting yourself or someone else? And it's usually SIHI, so myself or someone else. And having those conversations and getting them the help they need if they do admit to planning. And that's the big thing. Or do you feel this way? Do you have a plan? Those are the two questions you ask. And then, of course, with depression, you probably also want to be asking these things. We don't want them not listening to their bodies. And sometimes when your body's changing so much, you think, well, I'm just going to be so good looking if I just keep taking this, but I'm so horribly depressed. You need to listen to your body. Something's not right about taking that medication. So that's pretty much it for the obesity lecture. Good luck. I know this is a lot, and I will see you guys when I talk to you guys about upper and lower GI issues. Have a good one.